and do some introductions. So I think I know everybody, but my name is Rachel Halleck. I am the Deputy Director and Chief of Staff for the Division of Mental Health and Addiction. And in terms of this particular workforce group, or this workforce subgroup, I have some experience in leadership at Ivy Tech in the past, and some experience doing some outreach and some intentional program design around increasing workforce and access to education and specialized training for people in Indiana. And I have been fortunate enough to maintain some of the connections there with Ivy Tech. And we have, Jocelyn and myself and a few other people have had some conversations over the past year around some ideas that we might have in terms of intentionally increasing workforce in the behavioral health space. So this is something that I know all of us think is very important, but I'm very excited to be part of this meeting today. So I will just call people's names so that we don't have a weird popcorn situation. Jocelyn, would you like to introduce yourself?
I'm Jocelyn Kachaki. I'm obviously with DMHA. I am the, my title just changed, about to say the wrong one, other one. I'm the Behavioral Health Workforce Director. So, thank you.
Steve?
Steve McCaffrey. I'm the CEO of Mental Health America of Indiana and have been involved on a number of workforce committees and legislative activities. Mental Health America also houses a training institute and ICATA, which provides certification for people with behavioral health professionals.
Thank you. Alexis?
Hi, I'm Alexis Pless. I'm one of 4 1959 program specialists with DMHA.
Thank you. Carrie?
Hi, Carrie Gadwell. I am the CEO of Fort County, a community mental health center serving North Central Indiana.
You have a nice little mobile situation set up there.
Yeah, well, I'll take myself off video once it is I drive again.
That's okay, no worries. Katrina?
Good morning. I'm Katrina Norris. I'm the Executive Director for the Indiana State Psychiatric Hospital Network. And that means that I oversee the Indiana 6 state psychiatric hospitals. My interest in this particular topic is very similar to Rachel's as far as experience. Prior to becoming a state employee, I did recruitment for a very rural hospital, was involved in the National Health Service Corps, as a recruitment retention tool that I utilize for workforce development. I am a National Health Service Corps recipient, which means I got my loans forgiven to work in a rural area. I have a KDEC 5, which Steve mentioned earlier as far as credentialing. Have also been involved in obtaining grants to train peer recovery coaches. I'm an adjunct instructor for the IU School of Social Work. And active with the NASW Indiana chapter that obviously is has been very active in the legislature for workforce. Thank you.
Katie.
Can you hear me?
We can.
Awesome. I'm having audio difficulties today, so I apologize. So this is Katie Adams. I'm the CEO of Southwestern Behavioral Healthcare in Evansville. Glad to be here.
Glad to have you. Lindsey?
Hi, here I'll share my video and show my face here. Hi, I'm Lindsey Bale. I'm a policy developer for the Office of Medicaid Policy and Planning, and I'm acting as a designee for Allison Taylor, who is the Indiana Medicaid Director. I'm the subject matter expert for substance use disorder services for the coverage and benefits section of OMPP. I'm a bit new to the Medicaid and behavioral health arena as a whole, but I'm happy to be part of this conversation and to bring back the discussed topics back to OMPP.
Thank you. Sharon?
I'm Sharon Bowman. I am professor and chair of the Department of Counseling Psychology, Social Psychology, and Counseling at Ball State University. I'm also a psychologist in private practice here in Muncie, and I'm representing Indiana Psych Association and the Association of Black Psychologists.
Thank you. Glad to have you. And Matt.
Hey everybody, I'm Matt Brooks, the President and Chief Executive Officer of the Indiana Council of Community Mental Health Centers, representing the interest of Indiana's certified CMHCs. Obviously, workforce issues continues to be one of our primary challenges facing our industry. And I'm a big believer that no matter how good of a system we design, unless we have an adequately trained and licensed and prepared workforce, it's going to be very difficult to successfully implement programs. So I'm hoping this committee can work towards that goal. I'm glad to have Sharon here. I also hope that we can have university, college representation, because I think the ability to make this work is predicated around educating our workforce. And so I think that's something that we might want to think about too, is having and making sure that we have university and college representation so that we can collectively build a workforce together and what it's going to take to make that happen. Sharon, can you act on behalf of Ball State at all? Are you in the capacity of those other roles?
I act for everybody. You just don't know me, Matt. I act for everybody.
Right. Well, I know you a little bit.
I'm chair of my department, and we
Awesome.
train doctoral level counseling psychologists, master's level rehabilitation counselors, and master's level mental health counselors. And I do have access to colleagues across the state. So while I can't speak for everybody and I can't make everything happen here, I do have access to the people who have some power.
That's great. That'd be wonderful. I think it'll help enhance what we're trying to accomplish.
All right. Well, that's everybody. I am pretty sure I'm doing a double check here. All right. Well, thank you all for the introductions. I'm going to share my screen. Those of you that have been on a Behavioral Health Commission subgroup meeting already have a feel for the way the agenda is going in this first meeting, but I'm going to go ahead and share it just in case. Let me zoom in. So we already did introductions, and we are going to start by reviewing the legislation and basically what we have to do for this subgroup. And goals for our subgroup essentially are trying to sift through this giant issue of workforce development in the behavioral health space and try to determine what are our low-hanging fruits, what are some things that we can start working on today. As you all see, we have people from the educational space, from DMHA, from Medicaid, all here and present. So there are some things that, as we are talking about the recommendations that we want to give to the commission, that we could start working on today that don't have to necessarily be a formal recommendation that is going to be, you know, maybe a 1, 2, 3 year project. So there's identifying the low-hanging fruit is a really wonderful opportunity within the subgroup. And then more formally is trying to narrow down what we would like to do in terms of a final recommendation for workforce for the Behavioral Health Commission, with the understanding that hopefully whatever our recommendations are, that will help offer some weight to the issue that we need in order to push something or some things forward that we've needed for a long time, but for some reason have really been struggling to get momentum. So that's kind of why we all are here today. Typically with the other Behavioral Health Commission subgroups that we've had, we've been planning to meet once about every other month, just so you have kind of an idea of the frequency and cadence of the meeting. And then toward the end, what we are going to do, so this is, even though the Behavioral Health Commission is a little bit peculiar in the sense that it is intended to represent the behavioral health and substance use disorder needs for the entire state. Jay, who is the DMHA director, is written into the legislation as the chair. And so from my perspective, is best if we identify a chair for the subgroups that is not part of DMHA. So there's a little bit more neutrality and a little bit more of a kind of global issue and population perspective to make sure that we're reducing as much bias as we can. So at the end of the meeting, what we'll ask you to do is to send us some information if you'd like to opt out of being the chair. And then from there, we'll identify a chair and we'll keep moving forward. So does anybody have any questions about the agenda for today? All right. So I am going to go ahead and share this PowerPoint here, maybe. There we go. Okay. All right. So within the workforce subgroup, there are significant inequities with behavioral health access and outcomes in Indiana. And this group is going to examine those inequities through several different lenses, including racial ethnic disparities, socioeconomic disparities, and rural access. This group will also examine ways to increase the number of mental health clinicians in Indiana. And the legislation, so according to the legislation, we are supposed to prepare 2 reports. So our first one was due October 1st of 2020, and it basically said we haven't done anything yet because we hadn't, due to the pandemic. All of our Behavioral Health Commission action was really stunted and put on halt. And as you all know, we didn't really get this moving until toward the end of the year. We have a final report due by October 1st at the latest. And the areas that we have to cover are assessment and inventory, including mental health, substance use disorder, and childhood trauma, funding and data in terms of mental health systems, access to mental health providers, funding for mental health system and providers, youth and families, including suicide prevention, early intervention for mental health related disorders, treatment for substance use disorders, and system design and access, including suicide prevention, early intervention for mental health, and treatment for SUD. Additional tasks include reviewing mental health and substance abuse funding sources, including Medicaid, Recovery Works, local tax revenue, and block grants. And then we hope to make recommendations concerning these funding priorities and levels for mental health programs and services. We are supposed to establish the cost of untreated mental illness. That in itself is a pretty heavy lift. And evaluate the efficacy of our Dharma system and make recommendations for improving our current assessment and data systems. We have to, according to legislation, look at funding, access to care, system design. And under those 3 sort of umbrella terms, we would like to also make sure that we're looking at equity and social determinants of health, data, integration with other systems, and going where the people are who need prevention and early intervention or treatment, looking at administrative burden and red tape, how we utilize technology, and how we might be able to encourage collaboration, transparency, and innovation in mental health care delivery. Any questions about all of that? All right, cool. I think most of you have heard that song and dance before, so thank you for tolerating it for the 2nd or 3rd time. So the way today is going to go for the next 45 minutes or an hour, I would love to just have kind of an open discussion about the things we're seeing in terms of gaps in workforce, things around what sorts of strategies and initiatives are already taking place that we know about, who might we want to make sure to have at the table. Our goal here is not to it's to be really intentional about not duplicating anything. If we have things in the state that are working, how might we bring them together or enhance them or join forces with them? And what sorts of things do we maybe need to newly develop, if that makes sense? And I think one thing that's really cool about this particular commission is I think we spend a lot of time in different spaces talking, right? And talking about the problems and talking about the problems and talking about the problems. And then a lot of times the answers and the movement toward actually working on the answers gets kicked down the road a little bit. And I think within this Behavioral Health Commission, we will have the weight needed to actually start getting some things moving or to enhance the momentum of programs that we see and we know are already working. So with that, I am going to open the floor, and I'm going to be over here jotting things down. I'm going to be attempting to put kind of our priorities and initiative in buckets, and then communicating those back to all of you and starting to dig down a little bit more. So the floor is open. Let's talk a little bit about workforce, what we're seeing, what we need, what we know is happening already in the state.
I'll throw out one thought, and I want to get Steve's input from it. Excuse me. This session, there was an effort to improve the ability of addiction counselors to get licensed. And in fact, the legislation made its way into 1468 via 1467. And I'm using this as an example to stimulate the conversation. And the legislation was promoted by the Commission on Improving the Status of Children. I really appreciate the efforts of the Commission and what they're attempting to do. And the changes really speak to two things to me. One is by reducing the number of hours required, what direction are we moving in as a state with respect to expectation of licensure and education and training and clinical oversight in order to receive a license? And how does that stand itself up against the need to backfill and create extenders with programming, essentially OBHPs and others, with respect to what direction we're headed as a state? And that also speaks to issues around where we're trying to get with respect to reimbursement for these types of positions. If we're trying to reduce hours and make it easier to get licensure, are those expectations aligned with the state Medicaid program and DMHA's strategic objectives related to programs? And are the programs themselves aligned, the Medicaid programs and the reimbursement systems aligned with the licensure, scope of practice, and education required to achieve those positions? And how do we bring them into alignment? And in my example of the addiction case, my belief is that you can shift addiction licensure requirements all day long, but if those shifts are not aligned with what the expectation and reimbursement systems require through either the Medicaid program or even the Medicare program or even commercial insurance, there seems to be a disconnect between licensure expectation and reimbursement systems. And this isn't just related to the example I'm showing, it's related to all aspects of mental health and addiction, behavioral health type workforce positions. And to me, this is the number one issue, is how do we align what DMHA expects, what Medicaid expects, what the federal government has approved, against how we're training them through the education system, how we're preparing them through their clinical hours and expectations there, and with how the Indiana legislature in statute has defined those expectations and align them with these reimbursement systems.
And yeah, I can respond to that. And I'll just add where I thought you're going to go to, Matt, which I'm sure you meant to, is as it relates to telehealth, because that was one of the big issues was telehealth would only be reimbursed for licensed professionals. And does that make sense? So let me, I'll take Matt's stimulating conversation and try to make a broader statement from my perspective. For those of us that work in the government affairs space, every year there is, and I'll use the word fight, over what is appropriate for licensure and what various licenses can do, what it takes to have the license. People with one license want to argue about people with other licenses. And for the most part, the reason why there's so much fighting is because it's tied to reimbursement. Like everybody wants to act like it's about quality. It's really about reimbursement. And to me, it doesn't make sense to have a fight. Rather, so kind of what Matt was saying, it makes sense to figure out what we want our licensed professionals to do. Because right now we're saying they have to do basically everything because they're the only ones that get reimbursed. And figure out what we want them to do, what the qualifications are to do that, reimburse them for that. But then also figure out what else is needed, who else can do it that doesn't need a license, but could still get reimbursement. And so I'm a firm believer in licensure is cool, but it's not the beginning and the end, and that there should be a continuum. And, we're starting to see that, before we had, so I'm sort of guilty. I was one of the lobbyists to pass addiction licensure. And before we had addiction licensure, we had addiction certification. And I think it's a mistake to think that one replaces the other. And I think we have a continuum, and we're seeing it more and more across this country and in the state with the peer specialist movement. We're seeing that there's a certain workforce that can do certain things if they're trained and certified, and we can rely on their skill set and reimburse them. Well, that's also true with a bunch of other people. That's also true with people with associate licenses. That's true with bachelor's level, associate degrees or certification, bachelor level degrees and or certification, other certifications. And as we think about how to expand the workforce, I'm a full believer in let's invest in the universities and try to build out through, loan forgiveness or whatever is helpful to expand the, graduate level training and licensure. I think that's critical. But it's a mistake to say that that's the beginning and the end of the conversation. And I think we need to recognize that if we're going to meet the needs of the workforce, it's not going to happen just with master's and doctoral level licenses. It has to be a full continuum of certified people that that can get reimbursed somehow, which we need to figure out. Carrie was testifying on a bill a few years ago, and I told her that this resonated with me. And she made the point that the best way to expand the workforce is to expand the qualifications of the people already in it. And to me, that's a good starting point. And, it doesn't make sense to have mental health trained professionals doing addiction, but they're not trained in addiction, and addiction professionals doing mental health, and they're not trained in mental health, and people being caseworkers that are learning it on the fly, but really not trained or certified. And so I think we have, low hanging fruit. I'm not good with that. I know, because I think everything, I think in terms of larger systems issues, but there are people that, that we could, I think, build a continuum, peers on one end, licensed therapists on the other, and then build out everything in between. And I think that is a low-hanging way of addressing the workforce in a meaningful way. And so, for example, I'm just from our standpoint, ICATA offers the, I think Katrina mentioned the CADAC 5, and that's a certification for people that have mental health training, but it gets them up to speed on addiction. So we're building on what already exists and building out the workforce. And I can give you a bunch of examples of some of the ideas that we have in other areas too, but and I'm not saying it just has to be us. I'm saying that's a concept that makes sense, and it could be Ivy Tech, it could be whomever. And but I think that's the mistake that we make. And I'll just end by saying, I have been in many, and I'll just go back to the word fights, where I apologize if you can hear that.
You're going to need to put your pet bird on the screen for us, Steve. Or I should say Melissa's pet bird.
Yes, it is Melissa's bird. It's her fault. But I think that it's a mistake to think that certification and licensure are at odds, and that we should only have one thing. Again, I was very much involved in passing licensure. It wasn't my thought that meant that we should get rid of certification. Well, some graduate level schools and licenses do think that. And to me, that's a missed opportunity. And there's also the flip side, certified people that used to think that licensure wasn't important. I think this is about more, not less. And we need all options on the table to deal with the workforce crisis. And everything that we've all talked about the next pandemic that's coming, there's no way you can deal with it. I mean, thankfully, we did well with the legislature. We're going to have money, but that's not the solution. And we're not going to solve workforce by, graduating PhDs in psychology that can take over for the next 2 years. So we have to figure out something in between. That's my opinion.
And I think also what I'm hearing you all mention is, where is the balance between increasing capacity and maintaining high quality ethical services, right? Because I think anytime that we see a surge in recruitment or programs that pop up that are spitting out these certain sorts of credentials or degrees, like kind of in a pressured sort of way, then and so I'm speaking from a lens where I've recently had kind of a barrage of pretty significant ethical complaints come across my desk. And so just thinking about, and those will unfortunately have always been part of the mental health field and will continue to be part of the mental health field. But thinking about, it's not simply about cranking out professionals, but how do we do that in a meaningful and intentional way?
And I think just to tie a bow on it, I think we need to train people and license them or credential them for what we want them to be able to do and what they're capable of. And so, when Matt's talking about so if licenses are the only things that are going to get reimbursed, there's going to be a push to water down the license. And to me, that's just the wrong direction. And if we should have a high expectation of people with graduate level licenses, but that also means that they don't need to be doing casework either. There's another training and another group of people that are capable of doing that. And then we hold them to that standard. We hold the graduate licenses to their standard.
Katrina, I see your hand up. Oh,
I
sorry,
was
Katrina,
trying-
and then Carrie will come over to you in just a second.
I think I agree, Steve, that there's a scope of practice here that has to be addressed.
Mhm.
So if we're looking at the continuum of professionals, there are certainly things that certified peer recovery coaches can do much better than me with a licensed addictions counseling license or a KDAC, because they're in that boots on the ground situation of navigating the person to that treatment that requires that higher level of training depending on the severity of the incident. So I really think we need to take a deep dive into the continuum and the scope of practice for each of those credentials, each of those licenses. And like you said, Steve, if I'm a clinical social worker or I'm an LMHC or I'm a PhD, then I don't need to be doing casework. And I think that is we've seen that very clearly in Senate Bill 82 with the amendments that were made. And the original amendment that said, well, if you're a clinical social worker or you're a licensed mental health counselor, you must schedule an appointment for the person. And that's fine. We would do that if someone needed that, obviously. But in reality, that's much more casework and scope of practice. So I really think the aligning reimbursements, aligning scope of work, it is not going to water down the license, which obviously, Steve, you can attest to, was a huge fight, to use your language, to pass in Indiana. And we're just now getting Indiana to national standards in so many regards that we don't want to water our license at all. And we have to also then have discussions or maybe bring to this group IPLA so that, you know, they can look at their rules and they can look at their regulations that haven't, to the best of my knowledge, been looked at for a number of years, and just reassess some things to get us to that standard where we need to be nationally.
Carrie?
So I was just going to echo what everybody's saying here, and I probably will take this maybe a little step farther is, you know, so we're talking about defining what all capacity what we need, right? We're talking about then to the optimization of each of those practices. And so if I think about if I just say paraprofessional, okay, area, whether it's certified or not, you know, I think that there is, if I speak to the, you know, we're rural. And so I just want to speak from that vantage point, right? If I look at my retention rates in work in my rural area, I have higher rates of retention for my high school degreed individuals than I do any other group. Okay. So they might have spent years in the workforce. They really get zero recognition for all that social services work that they did for many, many years. But ultimately, in those rural areas, those folks they're living and breathing those communities, right? They're probably going to stay in those communities. And so when you're talking about leveraging a paraprofessional workforce, I think you have to think so you might have several levels of this. You might have the different needs of somebody who wants to break into some level of behavioral health. And I'm talking not the peers, because you have that kind of setup already established. But from a case management skills perspective, you know, you're going to have that group, which you're talking about certifying at a high school level. You're going to talk about what does an associate's degree, you know, what can you amplify in that? We had a pilot done with Ivy Tech where we looked at providing all of the soft skills, this is the Workforce Ready grant, while they provided some academic, preparation. And that really was extremely helpful. Then you might have a difference for somebody who's a bachelor's degree. I mean, to be frank, people who have bachelor's degrees aren't that well prepared to understand what they're getting themselves into, you know what I mean, with a degree in psychology or whatever else. And then you can take that, I feel like, a step further, which is that, you know, if you're looking at the ability to say, well, you want to bring more licensed folks to the table, you know, I think that's where you also have to talk about your optimization. I like the idea of saying, what do you really need a licensed person to do? What do you want them to do? I think you don't have to water down the standards, but I do think you have to be able to say, when can we get people into practice, right? So we get, you know, when I got out of school and I had my master's degree, and this was back in the day, I could get in and I could be working and I could be seeing people under supervision in different states, and that wasn't a problem. As a psychologist, when I got out of school, right, luckily I was able to get into a community mental health center and practice. But a lot of psychologists, right, they need some ability. They want to be in private practice. They want to be leveraged for other things. And we have no mechanism for doing that, right? So we also have to think about, when does the ability to practice and engage people truly at that more professional level begin? You know, and that is varied depending on what license you're pursuing. I think you have to look at the scope of practice, right? I mean, I'm going to go out on a limb. I'm a psychologist, so I can say this. You know, I mean, at what point, when Indiana had a structure years and decades or whatever it was ago to allow for the potential for a licensed psychologist to develop prescription privileges, when do you start to reinvest in some of these very highly trained professionals as an add-on, right, to then be able to support particularly rural areas? Many states who have gone this direction have had a great deal of success, you know, and in establishing further scope. Many mid-level licenses can probably further establish scope, and there doesn't have to be infighting amongst associations as to, you know, who can do what when. We all are probably going to have to give a little bit, frankly, okay, on our scope. That's just the reality. To move the disciplines forward, we can't all be rooted in just holding on to things that we, you know, were our cherished babies for decades and decades, when the truth is that other people can be trained to do that, so our profession can be advanced. I think as you're advancing, you might have more people who are interested in getting into some of these varying licensed stages. And then I'm going to say, let's not forget about our RNs, our LPNs, and our MAs. Okay, so one of the things we're not talking about is just the inpatient psych needs. So there is not a really great pipeline for psychiatric nurses. And so, and to be honest with you, people think, oh, well, why wouldn't you want to go into the psych? I'm sure that it's easier than, you know, doing general med surg. And the truth is that the first time you get hit as a psych nurse, you think to yourself, I'm out of here. Okay. So, you know, I mean, I think that you really have to think about whether, you know, even those particular folks and how we maybe consider that we behaviorally enhance them. You know, I know in integration, we talk about medically enhancing behavioral health and then behaviorally enhancing, you know, the medical field. I do think that wherever we can look at very non-behavioral health licenses and say, how do you also behaviorally enhance that workforce, makes a humongous difference in, you know, us reaching people who may not need the most intensive services. So that's a long diatribe, but I think about this stuff from, you know, the smallest, you know, frontline paraprofessional interaction to, you know, these larger licenses, even down to, you know, APRNs and psychiatry. We're probably not going to have a massive influx anytime soon of all those licensed folks. So, you know, we do need to think, I think, about how we optimize to the workforce that we have.
Hey, this is Katie, if I could have a moment. So just to kind of tag on to what Carrie was saying, you know, we're talking about preparing and licensure and certification, but I'm also mostly concerned about sustaining the workforce and retaining the workforce. And so my concern is, I was at a NatCon session yesterday that said that of the people that leave the behavioral health workforce, 90% of them leave because they're burned out and overwhelmed. And so I find it interesting that our paraprofessionals are the ones in Carrie's rural communities that are staying. And so why is that? Why is it that the paraprofessional, the peers, why are they the ones that are staying and our licensed staff are not? So that's a question for me, because in community mental health, it's hard to retain employees because this is very difficult work. You know, we have people that go through school and get the training and get the licensure and get prepared, and then they come and it's more stressful, it's different, it's overwhelming, it's not what they expected, the administrative burdens are higher than what they had anticipated, and they're just not prepared for that. And so they either move to private practice or they go work for Target, which is a lot less stressful and pays the same. So I'm sort of interested not only in how we get people to enter the behavioral health workforce, but how do we help assist community mental health centers or other providers like ours that are not for profit? How do we retain this staff?
Katie, if I may just echo that, I think we have to talk about pay. We have to talk about, in this work group, the pay range for mental health professionals. I've seen so many of my students earn a BSW and then turn around and go back to school and get their RN because they can't survive on that level of pay. but they know what nurses are making. They know nurses, and no offense, I love my nurses. I have thousands of, or hundreds of them, but they have no continuing education requirements for their licensure. All of those components are critical in this discussion. Is we have to know our worth, and the state as a whole has to know the worth of this workforce, and we've got to be able to pay better, because if not, you're going to continuously see that turnover rate just happen because the burnout, because the stress, because this is hard. And I will say this from coming from a rural community and doing work too, my peer folks stayed because they had a different passion. It wasn't about money. It was about their own recovery path and their own amends. And they really had this passion of giving back, that someone cared enough about them and they wanted to give that back. Not to get too 12-step-ish in this group, but my peer coaches loved what they did every day. And it was certainly not about money for them. At least that was my experience.
Well, and I see, Katrina, I think that's something that is such a complex, I think there's this idea, I think you said some really important, everybody said really important things here, but there's this idea that if you're in the field of mental health, behavioral health, substance use disorder, you have to be self-sacrificing to a level that means even like your livelihood. And I think as I appreciate the idea of salary being brought up, because that is, I think as a field, we preach self-care and, things like that. And then also as a field, we say, if you really mean it, you have to be willing to live, off of financial scraps. And so that's not really, those two messages don't necessarily line up. And I think that salary is definitely, and loans and all of these sorts of things are, because I know when I was starting out in the field, had I not had this exorbitant amount of student loans, my salary wouldn't have felt quite as abysmal, right? But I had the student loan payment that was, as much as a rent or a mortgage. And that, I think that is a very real factor as well. Carrie, is your hand up again, or was it still from last time? I'm assuming it's still up. Okay. So what I'm hearing so far is the big takeaways that I have gotten are around the need for a full continuum of professionals. We need both short-term and long-term answers. So we have we have been in a mental health and substance use disorder crisis, and we are predicting that we are going to continue to see a surge of this mental health need in our community. And so, starting with high school recruitment programs as an example, may be a great idea, but what do we do in the next couple of years, and salary? And I want to talk a little about, so just to kind of dig in a little around the idea of credentials versus licenses and cross-training people, but having some documentation and so documentation, I'm meaning a credential or a certification or a license. For myself as a clinician, I historically, when I was working in the field, saw it because my workload was so much, right? So I would be working 50 hours a week, easy to keep up with all of the needs of all of my clients and the administrative burden and, all of these sorts of things. And the idea of going back for a certificate or a credential seemed sometimes just like insurmountable, right? And so, it wasn't that I didn't care about the expertise. I would spend time, reading and attending trainings and doing all of these sorts of things. But the idea of going back for a credential with everything else that people are trying to juggle, it seemed like a really challenging thing to choose to do. What are people's thoughts on making these credentials more accessible?
Well, Rachel, this is Carrie. Sorry.
I think you've missed my hand because it's
I'm so sorry, Sharon.
with the background.
Oh, it
That's
did.
okay.
Yep. I am
Yeah.
so sorry, Sharon. I'll go ahead.
That's okay. I realized what happened there. It's just blending in.
I thought it was, yeah, it looked a little bit like the on that little square. Thank you for speaking out. Sorry.
That's okay. I'm going to change the background here in a second so it stands out better. I just wanted to comment that in the earlier conversation about licensed people, especially coming to rural areas and leaving at the drop of a hat, which is what I think it probably feels like sometimes, versus peer professionals or high school level or associates level folks who stay and seem dedicated. I think one of the other pieces of that dedication is that they are often home. You're often talking about people who are from the area.
Mm-hmm.
And so they're not going anywhere because they're dedicated to their home county or their home, whatever the area is. And sometimes you're, for want of a better phrase, higher licensed professionals, your master's level folks and your doctoral level folks, your medical folks may all be coming in to a new area. And if it's rural and there's not an appeal to keep them there, and there's not the financial appeal to keep them there, they're going to get up and run if it's difficult. So I think we have to find other ways we have to find intrinsic ways to convince people that they want to stay. I mean, I live in an area where psychiatric providers are few and far between, which is going to be true for most of the state of Indiana. We have to find a way to convince people that they want to stay, and it's got to be intrinsic. Money is going to be nice, and we all really could use that money piece, but if we can't find an intrinsic reason for people to stay, they're not going to stay.
Sharon, are there any intrinsic motivators that you have seen work or be effective in your experience in the field?
Honestly, no.
Okay.
Well, let me rephrase that. I think I live in an area where I knew coming in that that Muncie was going to have much more of an appeal to families than it would to singles.
Mm-hmm.
So if you come here and you're single, it's very easy to get up and go. If you can't find a way to make a family connection, it will be difficult. So part of it, I think, is finding a way to appeal to people outside of work. What's the family appeal? How do we, if we have someone who's coming in with a partner, how do we make sure we also find positions for their partners so they're more likely to want to stay? I have new faculty looking at coming to Muncie, and the first thing they say to me is, can you find a position for my partner? And if I can't find something closer than Indy, I know I'm going to lose that person. They're just not going to come. So I'm not talking about finding people to date. That's not the issue, but finding a way to make your area intrinsically attractive across the board outside of that individual person is something that's becoming more and more important for us.
Thank you. Yes. Carrie?
So I was just going to say, if I'm thinking about, I'll start with the paraprofessional end. Well, there's a couple things. So I think some schools will allow a limited number of credits for work experience, life experience, right? So I think that that's something we have to really consider here when we're talking about, any certification at that paraprofessional level, maybe. The other thing that I am thinking about is the extent to which some of that certification takes place more or less as a part of the onboarding process, right? So if I'm thinking about, and again, I'm only thinking through my CMHC lens for my skills trainers, right? You know what I mean? I'm always going to have a need for those paraprofessional folks. And so in doing that, and they have better engagement rates, right, than waiting for people to come into the clinic. But if I think about that, I'm going to have a problem if I have to send them to 1,000 different trainings that are away from the center. However, if it is that, today I train my own OBHPs. I have a policy that states this is all that they go through, yada, yada, yada. And I really think that if we were able to build something that if you achieved some level of certification on that front, that was really much more a part of the experience of becoming, right? And a part of that onboarding, whether it's, we should even think onboarding, right? I think we talk more about longboarding, that it's something that's a part of what you're expecting over a long period of time. I think that is, so they're getting the work experience while they're also in the process of getting the certification. And then a part of that job experience then allows the time for them to complete those, right? Just like we do for orientation. It's just maybe a much more robust experience than maybe, what might be provided today. And it would be a much more consistent experience. Hence, if somebody moved on to some other different position or moved on to a new company, instead of literally having to start over from scratch and go through people's, own devised plans, I think then they have kind of this universal credential that allows them to move amongst not just CMHCs, but really amongst a variety of providers. It allows a path for a peer to become, an OBHP longer term. I just think there's a lot that can be said about how we just use the time that we all allot for orienting people to achieve these credentials.
And I think that is a really good point as well, because, I think about my experience over the years, and I think probably 90% of the time, it was literally like, hey, here's your caseload, go take care of them. You know what I mean? And onboarding and training, and how do you be a good case manager, and how do you, I saw Katie put in the chat, how do you do clinical supervision or peer supervision well? I think supervision is a really integral part of avoiding burnout, because when you're shouldering the emotional toll of all of the things that you're doing within the mental health field, if you don't have a solid supervision support, that really detracts from your your just ability to take care of yourself. And we know also that people with trauma backgrounds are, in the social service field, we are more likely to have people with trauma in their background than most other fields. And vicarious traumatization and all of those sorts of things are very, very common and very not often talked about on an individual supervision level. And I think all of that, yes, is very important. So I'm hearing now, I'm hearing kind of these three within workforce that we need to be focusing on, which are developing early interest in the field. And so I would think, and we haven't gotten there a whole lot yet, but around doing outreach at even the high school level around what does it mean to be a social service professional or a behavioral health professional, and how can we kind of grease that pipeline in a way that people understand that this is even a career option or career pathway for them. And then this idea of early engagement for people that are hired on, and then how also do we retain people through flexibility, creating an environment, whether it's in the area or within the agency, that will cause people to stay, considering morale, onboarding, clinical supervision, and upward mobility. If I could shift the conversation just slightly to focus on how does any of this look different when we talk about intentionally engaging people who are identify as members of the BIPOC community, the LGBT community, any sort of specialized population where representation is a really important factor in a person's connection with their therapist and kind of visualization of a recovery journey. How does this conversation change, or how do we tailor the conversation to not only keep general workforce development in mind, but talk about the importance of recruiting and retaining representative populations?
Telehealth has done wonders for some of that.
Mhm.
As one of the few African-American psychologists in the state, I have had clients reach out to me and reach out to my African-American colleagues, many of whom are based in Indy. We have had potential clients reach out to us from all across the state because they couldn't find a therapist of color in their area. They weren't in a position to drive down to see us
Mhm.
physically. And this allowed an opportunity to do something they hadn't been able to do before. I think the same thing would be true with other populations. In fact, similarly, I was looking for a therapist who could, who spoke American Sign Language
Mm.
for a client, and we were struggling to find someone locally. So telehealth has been a wonder in that way. Again, the acknowledgement of the need is probably the first piece.
Mhm.
And then the appeal, and so I'm going the other way from the workforce piece, but it's the appeal to the population we're trying to reach so that they know that we exist. And then making sure that we have enough people who can do it and are not burnt out in the work so they can continue to do it.
I know we've been making some efforts through our Racial Equity and Leadership Committee, and it's really been well received by the participants in terms of, having and supporting within our workforce individuals with color being able to really express themselves openly and the challenges that they face, and then also encourage leadership, because I think it goes beyond just getting them hired. It moves into, this has to become integrated into our leadership positions and into our whole system. It's not just identifying and trying to get them in. And I think we have a responsibility. I think obviously colleges and universities encouraging individuals there. And I think we need to continue to ensure that, it goes beyond just cultural competency training. It's a lot deeper than that. There are a lot of ingrained issues that need to be overcome and confronted. And I think those are going to help Rachel move into the direction that you're alluding to position us for not just a strong workforce, but a well-balanced workforce in terms of its diversity, in terms of its ability to respond to the needs of society individually, where people are, and meet people where they are. And I think that goes a long way, whether it's LGBTQ+, whether it's people of color, all these areas need to have a real reckoning, if you will, so that we can make sure that our system is properly prepared. So we're trying to make efforts there, and it seems to be going pretty well, and we're committed to it.
And I'll just add, I would agree with Matt that it's more than training, but it still includes training. And you can do training and certification of individual professionals and providers, and designate them so that the public or special populations that are looking for a particular professional or organization that would be receptive to what they're looking for. There are ways that you can identify those people and make, connect the dots that right now, it's a Google search that may or may not be successful. So I think, whether we have good intentions or whether or not we try to take those good intentions and make them intentional in terms of actually how we put together our workforce, those aren't exactly the same. And training and certification can be a part of that.
Yeah, I think the idea of how do we, within our agencies, for the sake of retention, recruitment and retention, kind of make our agencies scream cultural competency and validation and affirmation, and and there's a concept also that is close to cultural competency, which is cultural humility, right? Is the idea that I don't have to be the expert in every culture, but I have to have the humility to identify that it is a factor and that it's something more that I need to consider and to learn about and to explore with my teams and the clients that we're serving. And I think we have a long way to go. And I think every step that we make in that direction is definitely going to help with retention. Because if you think about, people that are identifying as part of the BIPOC community or the LGBT community, or any other sort of population that isn't the mainstream, especially when it comes to our mid-levels and our psychologists and psychiatrists, it's very easy to leave a workplace that doesn't feel healthy and affirming to start your own private practice. And I think we lose a lot of really great clinicians because of that. And we can and should and need to do better. Okay. What else? Anything else that we want to make sure that we get down for this initial conversation?
Rachel, can I say one more thing on nursing? Is
Absolutely.
That okay? I was just thinking about this. With all the movement towards thinking about, crisis respite beds, crisis stabilization units, et cetera, I think it also further highlights the importance of ensuring that we are addressing the nursing workforce, and then in addition to that, the training in behavioral health, because really a lot of those models, from my perspective, they're very much nursing-led models. So really to get to a place where we have probably a really hardy crisis response system, it means, I really feel strongly, it means leveraging nursing in a way that probably in behavioral health to date we have not done. So I was just thinking about that and wanted to mention that. Sorry.
No, that's actually very helpful. I think a lot of times nurses that end up in the psychiatric space really, at most have had a psych rotation, and that's been the majority of their training. And I have worked in a inpatient psychiatric hospital, and it is, if you don't have any training, I was fortunate because I was in my master's program when I started there. I cannot imagine trying to understand and navigate the mental health space without some specialized training in behavioral health. I think it would have been very challenging. And I saw that some of my colleagues that were nurses, that was a very frustrating and isolating experience for them as well. Okay. I think this is all, okay, so I'm going to just kind of go over the stuff I have written down that will be for us to think about in terms of our next steps for this group. Our next steps for this particular group, I think it will be important to kind of whittle this down into the categories of short-term and long-term, right? And with the idea that the long-term is going to be our recommendations to the commission and the things that we need this kind of added force and weight behind to get it moving. And then our short-term recommendations, there's no reason why we can't start those things now and start having some groups that are outside of the Behavioral Health Commission to start moving on some of these. Before I do this, does anybody know of existing groups that we should be engaging in conversation or that we should have at the table?
Well, I've served for some time, and we sort of fallen off maybe a little bit. But the governor's workforce council, behavioral health subcommittee, and Allison and myself, Hannah Maxey, there's a group of us that are on this committee. And Hannah's done quite a bit of work in this space, so she can provide some more information. But I don't want this meeting to be more just reviewing the issues.
Right.
You know, it's about, I think Steve was even alluded to it earlier, you know, it's like we could think beyond the low hanging.
Yep.
We know the low hanging. We need to think broad. And
Yep.
I think, you know, but yeah, that's one group that I know has done some work around this stuff. And I also want to lead in, we do an annual salary survey, and within some level of confidentiality, we'd be happy to release some of that information to the committee members to better understand, as we are the largest behavioral health workforce in the state. And that might provide some insight into, you know, where we are. And just as an example, we talked vaguely about salaries, but, you know, the 75th percentile of our master's level professionals, $52,000 a year. $52,000 a year. And so that right away tells you the scope of the challenge, because the expectation for that professional against where the salaries lie. And we also break it down by different parts of the state and peer group, so you can get a sense of you know, where things land from a salary perspective. So that's some additional information we'd be happy to make available. And I know our National Council has some national data as well around behavioral health workforces that we can probably draw upon as additional resources.
Yeah, this would be great. Thanks, Matt. Katrina?
I think it would be, excuse me, interesting to bring in the Indiana Rural Health Association, because we know we have that rural access component as required, getting some of their data as well in regards to workforce. And we have to talk to the licensing agency. They have to be a part of this discussion to move it forward on that broader scope.
I agree with you. And just, I'm going to brag on her because I know she won't say it herself, but just to show Katrina's commitment to helping the workforce and social workers, she, as a state employee, she had to take a vacation day to come to the State House to testify in support of expanding social worker capacity in Indiana. And I think that speaks a lot to Katrina's commitment to her profession. And I think we can certainly draw on some of those things as we move forward.
Thanks, Matt. That was really nice. Unnecessary, but nice.
Okay, so what I'm hearing is, you know, this kind of these three buckets of developing early interests, getting people into the field, and then retaining them. I've heard some examples around how do we expand the workforce that already exists, perhaps through offering credits for life experience, and how do we create flexibility in terms of, or how do we increase retention for folks that we have? I think something around even some training for leadership around internal leadership development and maintaining and developing employee morale and things like that might even be something that we look at some point, because, you know, I know that when I, just using my own experience, when I got into my first leadership role, it was because I was a good therapist, right? It wasn't necessarily because I had any idea how to manage people. And I know that I have seen so many colleagues have that sort of thing happen to them and just get totally burnt out, because managing people is really hard. It's really hard. And so how, and then there are some days, you know, that I think all of us have probably experienced that it's like everything we can do to keep ourselves sane. So the idea of like also having to figure out how to keep our teams healthy and happy is it's difficult. And if we don't have the tools easily accessible to create a strategy around that, it makes retention very, very difficult. So that might be something that we looked at as well. And then how do we increase recruitment and retention of, I guess I'll just say special populations, for lack of a better term, in terms of the BIPOC community, the LGBT community, and other sorts of specialized groups. And I got a list here of folks that maybe we need to be chatting with and engaging in this conversation. And then Carrie, your point about nursing. How do we, and nursing in terms of the greater scope of integrated health, how do we support move toward integrated health without throwing our previously kind of pigeonholed medical only providers into the behavioral health fire in a way that's going to totally burn them out. Okay. Anything I missed?
Rachel, I don't know if you, I'm not saying you missed it, and I don't know if you want to include it.
Okay.
Because it's not low hanging, but I think it is going to be a big issue that's a policy decision whether or not we want to weigh in on it. Matt spent a lot of time this session on the issue of non-licensed telehealth reimbursement. So just big picture. So forgetting about that particular issue as it relates to him, but big picture, 60%. If you know, I see different studies. Behavioral health's going to move into telehealth, 40, 50, 60%, whatever. If that is the future, and if only licensed professionals can provide it, then we're not going to be able to keep everybody else. And so is that an issue that this group wants to consider? You know, Matt had a proposal at one point that I thought made sense. Well, I don't even know if it was, I think it was if they're Medicaid reimbursed, then they could get reimbursed for telehealth. Or maybe it was if you're a state reimbursed. Anyway, I like the state better, but if you are reimbursed by a public system, it seems to me that's another way of going about telehealth. So again, I don't know if you want to consider it in this group. I think it's a big issue. I think it's a big issue for the future, but it is going to be really limiting if we limit forever to licensed professionals.
Yeah,
we're not even sure if Senate Enrolled Act 3 actually restricts different providers who are authorized by the Medicaid program to provide certain services. There may be some legal issues there too that need to be examined in terms of the difference between what Medicaid is authorizing and what is authorized in state statute. Because as we know, Medicaid is approved by the federal government in the way that Indiana manages it.
Well, and I will say at minimum, the idea of empowering and developing OBHPs is, I think, really important, especially in terms of growth in various areas of the field. And I think often, you know, these are our folks that probably need the most support and get the least, really. I mean, they're out there doing some really tough work. And that stepping stone for some people, and for some people that is the, you know, kind of their career goal. Either way, supporting them and making sure that they have the ability to be successful in their careers is part of this as well. Absolutely, I do believe that. So yeah, we can include that in what we're talking about here. And I think that's part of why, you know, as the executive branch of the government, we have to, why Katrina had to kind of take a vacation day to speak on the mid-level diagnosis issue, you know, in the executive branch operating in that capacity. That's something that, you know, my DMHA has to stay relatively neutral on. But I think in terms of workforce development, it is definitely a relevant issue. Cool. Okay, so with the interest of time, what we will do today is Tuesday, as far as I know, it is Tuesday. If you would like to opt out of being the chair of this subcommittee, please shoot myself, Alexis, and Jocelyn an email that just says, hey, I would like to opt out of being the chair. If you could do that by close of business Thursday, that would be great. And then end of this week or early next week, we will send out a survey so that we can, as a group, select who we want to serve as our chair. And then we'll talk with the chairs to say, hey, would you like to have a co-chair? How can we help this be a role? This is intended to be a role that is driven a lot by the chair and the members of this committee, but that is manageable. So if you are selected for the chair, you will also have the support of Jocelyn, Alexis, and myself in terms of administrative support, help scheduling and recruiting people and doing outreach and things like that. We want to make sure that whomever is chairing isn't inadvertently taking on another full-time job. We just want this to be driven by somebody that would be a good fit for that sort of role with whatever support that we can offer. So if you could send that by close of business Thursday, otherwise we will are on board with being the chair, and then we'll send out a little voting tool. If you have any questions or feedback, don't hesitate to reach out. And with that, are there any last minute thoughts, questions, anything like that?
I just wanted to comment on the telehealth, the Senate Bill 3 that we've been discussing here. Medicaid is making amendments to our state plan right now in accordance with some of those the legislation that was passed. So I like hearing some of this insight and potential problems that we're going to see by implementing this sort of policy, especially from the behavioral health side and the licensing issue. So I appreciate sitting in on this and hearing that conversation.
Thank you, Lindsay.
Do we need to look at scheduling another meeting right now, or did you guys want to wait till later? What would you guys prefer to get it on your busy schedules?
If you're all comfortable, we can try to schedule it now so that you have it. Jocelyn, do you want to throw out a date a couple months?
I can throw out something, sure. Let's see. So today is May, so let's look at July, sorry. Okay, so the 4th. If we want to keep it on a Tuesday, if that works for everyone, July 6th is in 2 months. How's everyone's schedule looking for that?
When's July 4th celebrated?
It's on
July
a Sunday.
Sunday. So we probably, I think, stay off to maybe Monday, I think.
Yeah, Monday is our state holiday.
Great. Okay, thank you. So the 6th, would everyone be available?
Just throw out, I bet a lot of people take off that week.
Yeah, I was going to say maybe the week after.
Oh,
yeah.
do you guys?
Thinking about taking off that.
I have to save my time, so I'm not doing that. How about the 13th then? Do we like Tuesdays? Okay.
I'm okay.
Works for me.
Awesome. Okay. So how about we do the 10 o'clock work again? Okay.
Do it.
All right. So I will send out a placeholder for you guys for July the 13th at 10 o'clock.
All right. Thank you, Jocelyn. And thank you so much to everybody on this committee. I really appreciate your candor and your feedback and your brainstorming. And I'm excited to see what high level, high hanging fruit that we can tackle. And I think